Hello, good morning, everybody, and welcome to AHP Week. We've got another session today, which is about AHP's leading research. Just a bit of housekeeping before we start. Obviously, the session is being recorded for those that are not able to attend live, so they'll be able to view it on catch up. So please tell your colleagues who weren't able to attend today. You can turn off your videos or keep them on, whatever you prefer. We just ask you to keep your microphones muted unless you're actually speaking. You can ask a question for the speakers or make a comment, either using the chat function or raising your hand if you want to speak. We've got a series of talks today from researchers across the region who'll tell you about their specific area of interest. But before that, I'm delighted to welcome Hazel Rodham from Health Education England. Hazel has led all of the AHP research and innovation strategy for England, which she will tell you about in her presentation. And Hazel will also chair the session, so she will chair the 5 speakers that we have from across the region. So I'm going to hand over to you, Hazel.
Thank you very much, Lindsay. Thank you for the invitation. I'm delighted to have the chance to talk to you all today and to hear the presentations that are coming up in just a short while. I also want to mention that I have got links with Leicestershire. So this is a long time ago now, but I lived in Melton Mowbray for a number of years. I worked in the area and we've visited many times since. So I do feel a link with you all. And I'm delighted to know that although I'm up in Lancashire at the moment, we've got this connection. So many of you may have heard me talk before to introduce the research and innovation strategy that we launched for allied health professions, and that was commissioned by England, by Health Education England. So this is what I'm going to talk about today. I'm going to try and do just a little helpful recap of where we've moved on to and give some links and further resources that might be useful for you to share with other colleagues as well. Okay, so it's really important that I just explain that this strategy was co-produced. All the 14 allied health professional associations worked together on this. So that was the piece of work that we did over the last 12 months in 2021, from January until the end of the year. And then we launched the strategy publication in January this year. So as well as the 14 professional associations, we also worked very closely with a lot of support from the Council of Deans of Health and also with CAPA. So CAPA is the National Strategy Board and hub network across the country. And of course, the professional associations and CAPA are UK-wide organisations. So they represent the voice and the perspective of AHPs who work across all geographies and all the breadth of different work sectors and employers. So it's important that this piece of work was produced jointly and had absolutely unhesitating consensus on what our vision statement should be. Just to comment a little bit more about CAPA, the role that I have at the moment is a fixed term contract. I was employed by Health Education England to develop the strategy, to launch the strategy, and to initiate the implementation work that I'm going to tell you a little bit more about today. I'm working very closely with the National Strategy Board of CAPA, Council for Allied Health Professions Research, because they are the ones who are going to continue this implementation work over the coming years to really push forward more than ever before the reputation, the visibility and the influence of allied health professions research. So they have a network of hubs on the ground. They're all refreshing the way that those hubs operate and the focus, the purpose of those hubs and the way that the hubs work together more as consortia across geographical patches. We're also refreshing the professoriate of CAPA. So that will give the strategic direction and academic leadership and mentorship across our health professions. So if you're already aware of local CAPA activity where you work, then that's fabulous. Do keep up those connections, because increasingly that's going to be really important as two-way communication to find out what's happening nationally and how you can align with that, but also to contribute and feed into that. So really hope that in the coming years, CAPA will be much more interactive as well in two directions. So this is what the strategy document looks like. We tried very hard to make it slim, fit for purpose, punchy, to the point. This isn't a PhD thesis for people to have to read. And there's a link that you can find and download this document from the Health Education England website. It's easy to find if you simply Google Health Education England, Allied Health Professions Research and Innovation Strategy. But we don't expect that everybody necessarily needs to digest and know this off by heart. But what is there are some bold, ambitious vision statements. So what I've done, which might be useful to you to share with colleagues, is I've made a one-page at a glance view, a summary of what our vision statements are, links to where you can find them, dates of what's coming up next. I've also made a sub 5-minute YouTube video, and I think maybe you wish to encourage other people, other colleagues, to make a cup of tea, sit down and watch that introductory video if they don't know anything about the strategy or where we've got to so far, and just say to them that they'll have finished watching the video before they finish their cup of tea. It's just under 5 minutes, so it's practical. Hopefully it's something that you can share with people, and that will get them started in conversations to talk about what does this strategy mean for you, wherever you work. This is meant to be a message to everybody, whether you're on the front line in clinical practice, if you're in an academic role, if you're in a clinical academic role, or if you are working in any sector at any stage of your career. So this is to get the conversation going, and how are we going to transform the direction that we want to keep moving. So here you are. This shows the 3 key vision statements, and each of these vision statements for our future direction is underpinned by strategic aims, strategic objectives, and descriptors of what good will look like. And we make it very clear that when we talk about research, there's often a lot of expectations and misrepresentation of what we mean by research. It can be the dirty word that turns people off, and they don't want to have conversations. They say, no, I just want to do my job as best I can. You're interested in research, you talk about research. But by research, we've defined this as service improvement, quality improvement, innovation. It's about all the activities that we need to drive forward quality services for people and families who need them, and for us as professionals delivering these services. And we need to be smart. We need to be able to measure where are we now and have sensitive and appropriate relevant measures of our progress towards these aims. But the way that we will achieve this is by, more than ever before, really integrating strongly between academic experts in research and service improvement and the frontline practitioners, the workforce, who know what are the priority needs facing people delivering the service and the experience of people receiving our services. So we want to improve practice. That's the whole point. And these are our sort of continuous quality markers, our drivers, and this will include making really sustainable and meaningful connections, integration and investment between the HEI, the academic sector, and the service providers and commissioners. And we're looking at driving forward capability building and opportunities for individuals, and that might be in academic careers and clinical academic careers, so that we've got that leadership, but engaging the wider workforce so that we actually get research into practice to make a difference. We need both sides of the same coin. And for that to happen, we need infrastructure and investment in processes and systems. We also need the cultural change. We need people to be understanding and expecting that this is part of our professional role as allied health disciplines, to be embracing this whole agenda. We're going to need leadership. We're going to need role models and mentorship. And we need to set up systems and processes so people can more easily access these types of support systems. So the CAPA, who I talked about a few moments ago, CAPA nationally, again, are refreshing their CAPA Research Champions scheme, giving a much more focused role and purpose to that scheme. And we've got meetings coming up to develop toolkits and resources that people can share. Okay, so I've described these domains about how we need to develop capability in individuals, capacity in the wider workforce to get everybody engaged and understanding, what does this strategy mean for me? How can I use this as a lever in my own career to get to do the quality improvement activities that I know would benefit the families I work with? How can I learn new skills to demonstrate the effectiveness of the way that I'm working? So scientific skills in measuring, evaluating the ways that we work. We need the systems and processes in place to support all of this, and we need this culture change, this expectation that this is part and parcel of how we work. And this framework is what I'm using to measure our evaluation of implementation. So we're moving forward in terms of implementation with many partners, many stakeholders at the very highest strategic level nationally, and on a regional footprint, particularly trying to link in this AHP agenda for driving change for research and innovation with the ICS boards that are being set up, trying to connect through the AHP councils and the AHP faculty network to make sure that AHPs have a voice at every level, from national to regional to local to organisational. You can be part of that, and I would love to hear from you. So at the end, I'm going to also share my contact details again, so that I can help and respond directly to inquiries about how we can link in between regions and within local areas. Now, then you'll also be aware that just a couple of months ago, the Suzanne Rastrick announced the launch of the AHP strategy for England. And I'm delighted that of their enhanced foundations, our research and innovation strategy is in there. It is embedded, it is fundamental. And again, this gives us a really powerful lever for change, for demanding change, for supporting evidence that we need to change. And it gives us the language to talk to our influential stakeholders. So if you're, again, not familiar with the whole document, just look at this page. This page here demonstrates in such a powerful way how we can achieve this and work towards it, grassroots upwards as well as strategic level downwards. So again, I just want to conclude by inviting people to contact me, but also watch out for this date. We are running an event which will be a completely online free event on the 25th of January 2023, and that's like a birthday celebration. It's the anniversary of the launch of our strategy that happened in January this year. There will be limitless places, but you need to book a place, you need to reserve a place, and the publicity will be going out within days. I have a meeting this afternoon to confirm that process. So you'll be able to reserve a place. It's only a part day because we realise how busy everyone is, but we will be having lots of exciting announcements and news broadcasts and lots of inspiring and exciting presentations during that 10:30 to 2:30 slot on the 25th of January. So I hope to see you online. I hope that you'll put that date in your diary. It'll be recorded and available afterwards for anyone who's not able to join us on the day. So I've got to the end of where I'm up to. Thank you for listening to that, and you'll be able to share that recording with colleagues and invite them to listen to it too. But now I have the pleasure to begin to introduce our speakers, who are going to give you insight into what they are doing on the ground across your region. So our very first presenter today, I'm going to stop sharing and invite Enya to be able to share your slides and talk to us now. Okay, so all our speakers have 10 minutes to present, and during that time, Lindsay and myself will be watching for your comments, your questions coming up in the chat box. And then I will chair those questions. We'll squeeze in as many as we can before I invite the next speaker. Okay, so we're ready and listening. Thank you, Enya.
Thank you. And just check you can see my slides, okay. Great, thank you. So I'm Enya. I'm a clinical academic physiotherapist at the University Hospitals of Leicester. I'm a postdoc and I work across the COVID rehab team and the Respiratory Biomedical Research Centre. So today I'm going to speak to you about our study on COVID rehab, and hopefully that will make sense as to why and how that can inform our clinical practice as well. And that follows on nicely from what Hazel was saying and why clinical academia is so important. So I won't give too much background about COVID because I'm sure you all know and have lived it yourselves, but certainly early on there was some idea that these people who had COVID may not fully recover and may need some help to get back to where they were at before. Particularly, we thought that would be aimed at those who were in hospital. Though recently we've learned that perhaps that's not necessarily the case. So we've had a lot of guidance from NHS England. We've also had some guidance from the British Thoracic Society on COVID rehab. And then alongside that with NICE and then at UHL, we've developed a clinical pathway with that in mind. Early on, there was kind of consensus that a pulmonary rehab model may be best placed to be modified for those with the needs of COVID, because early on they certainly were more respiratory symptoms and did kind of mimic what we were used to seeing in pulmonary rehab. So we've found from our clinical service data that of those that were hospitalised, approximately 1 in 4 are requiring rehabilitation. And that's not necessarily those that were in ITU or in kind of high dependency units. So that there doesn't necessarily seem to be a pattern of people that require further follow-up that we've been able to see. So that was originally as part of our routine follow-up in clinical care. We would follow them up over the phone and see if they had any extra needs for rehab. But obviously that means those that were infected in the community, we don't have an understanding of how many of those would need additional support. But it's estimated by the Office of National Statistics that those there are about 2 million people suffering with long COVID in the community, and that some of those may need rehabilitation. So certainly early on, we were very aware of the acute symptoms of COVID, and breathlessness and fatigue and pain were quite common. That's somewhat changed as the waves have gone on, but certainly with the follow-up, there seems to be fatigue, breathlessness and joint pain still seem to be the main symptoms that continue after infection. And this is really early data. This is from 2020. These are 60 days after their initial infection. And a lot of those symptoms that are listed are possibly modifiable from a rehab program, certainly a traditional pulmonary rehab program, and then obviously we would adapt a program for COVID specifically. But these are certainly the symptoms we're used to managing as part of our pulmonary rehab service anyway. So we did develop a COVID rehab service, and we did pilot that and publish some of that data, which was quite encouraging. And then on the back of that, we have started a fully powered randomized controlled trial to assess that intervention. This is as part of the larger FOSP COVID trial, which you may be aware of. This is a cohort study following people who were hospitalised with COVID. This is from some additional funds that they had to do an interventional trial. So the aims is to understand the clinical effectiveness of recovery interventions following hospitalisation with COVID compared to usual care, and understand the acceptability of the interventions. So this will include a face-to-face programme and a digital programme, which I will get onto in a moment. And then we have some secondary outcomes to try and understand the mechanisms, so the immune response to rehabilitation and the muscular response using biopsies. So this is across 2 centres in the UK that already had established COVID rehab programmes, so Leicester being the primary site and then Newcastle is our second site. And this is a randomised parallel group trial, which will compare face-to-face and online interventions to usual care. And that is quite a complex randomisation process, which I'll explain, but the idea is that the groups will be equal by the end. They can be recruited from the FOSP study if they've agreed to be contacted, or from our medical follow-up if they are referred to rehab that way. And we're aiming to recruit 159 participants, and our primary outcome is the incremental shuttle walking test. So once people agree to take part in the trial, we determine whether they would be able to do both or just one of the interventions. We didn't want this to be preference-based, because that carries some bias in itself, but really it's what they can access. So there's a large proportion of people that are not digitally literate or don't have access to the internet. And there's also a few patients that wouldn't be able to commit to face-to-face. So we give them the option that they can still take part if one of those options isn't feasible for them. But so generally we decide whether or not they can do either of those interventions, and if they can only do one, they'll get randomized on a 2-to-1 ratio. So for example, if you could only do face-to-face, it would be 2-to-1 face-to-face or usual care, and the same with digital. But if you could do any of those interventions, you're randomized on a 1-to-1. So this is a little bit more flexible than a traditional randomized control trial, and it means we're not unnecessarily excluding people that wouldn't normally be able to access one of those interventions, and it's a little bit more like routine clinical practice. So our face-to-face rehab is twice weekly supervised sessions for 8 weeks, and this is based on a modified pulmonary rehab program using exercise and education. So our exercise program is a combination of aerobic exercise using walking based or cycling, and a strength training program, so for the upper limbs and lower limbs. We would supervise them twice a week for 8 weeks, but the idea is that they would do a home exercise program as well, so exercising hopefully about 5 times per week. And then the education sessions are around discussions on common symptoms, and we use handouts from the Your COVID Recovery website to support and facilitate that discussion. Our online rehab program is using the Your COVID Recovery website. There's a second element, a password protected element to the site that's only accessible for those that have had an appointment with a healthcare professional. And this works through 4 phases over 8 weeks, so 2 weeks per phase. And the idea is it mimics face-to-face as much as possible. So we'd still advise exercising 5 times a week and then point in the direction of those educational sessions as well. They would receive phone calls every 2 weeks to support them onto the next phase, and they have access to messaging services and things like that if they need extra support from a healthcare professional. And then so far at the moment, our usual care is just a routine follow-up as determined by NICE. So they would be under the medical clinic anyway. And if they were referred to rehab, they would get rehab at the end of the trial if they weren't allocated to that during the trial. So our primary outcome is the incremental shuttle walking test, which is a test of exercise capacity. We also use the routine collected data and FOSP, so a lot of health-related quality of life questionnaires and some other functional measures such as the short physical performance battery. We do strength testing as well using the QMVC. And then we had some additional markers that were not routinely collected on FOSP, but were still relevant to us. So as I mentioned, we have a bit of a subgroup analysis or an exploratory analysis on inflammatory immune markers and skeletal muscle biopsies. And then we also added in measures of post-exertional malaise, which was important and raised by our PPI group. And then we'll also finish up with some qualitative interviews for patients and staff around rehabilitation and the facilitators and barriers to that. So they need to have been referred to rehab and safe to exercise. There's some concern around some people exercising with these symptoms. So those that have debilitating fatigue are excluded, certainly if they're not able to leave the house or are bedbound, or if they have noticed their symptoms get drastically worse with activity. If they're currently in hospital, obviously, or if they currently have an ongoing infection, then they would be delayed. If they've fully recovered, then obviously we would exclude them, or if they have other persistent symptoms that we think may be a result of a different condition or might need further investigation, or if they've already completed rehab in the previous 6 months. So this study opened in February this year. We've had quite a rapid recruitment since then. So we're aiming for 160, 159 in total. And as of when I put this slide together, maybe a week or so ago, I think we were up to 100 patients at that time. So that's across 2 sites. Newcastle started slightly after us, so they're aiming to recruit about 60, and we're going to do about 100 between us. So we're hoping to finish recruitment by this year, and then hopefully we'll have some results to share after that. So I'll just thank everybody. This is a part of a massive effort of people. So we have a lot of working groups within FOSP, but particular mention to Sally, Rachel, Neil, Will Mann, Tom Yates, Letty, Yanis, and then Molly and George, who are doing a lot of the work for us. So thank you. I'll take any questions if there are any. I'm going to stop sharing so I can see.
Well, I would like to thank you straight away, Dana, for that lovely presentation. I was fascinated to listen. I'm just sharing my screen to show who is coming up next. Sorry, I just need to advance to because I forgot to put for all the viewers our list of upcoming presenters. So this is who's coming next. But I'm just going to take one moment. I haven't seen any questions come in the chat. So another reminder, while you're listening to all our other presenters, please, any questions that you've got, don't lose them. Write down your thoughts so that we've got those and we can feed them in. I've just got one question that I'll give you now, and then I'll introduce our next speaker. So Dana, it's fabulous to hear about your experience of working with other researchers and with the 2 centres in this large-scale sort of randomised controlled trial. What about the reaction of other colleagues closer to home who are aware about you doing this work? What curiosity has there been from people about how you got started in this and what your experience has been like of being a researcher in frontline practice?
I mean, it's really handy because I work in both teams. So it's a good example of when research and clinical practice can go hand in hand. So at the moment, we have a COVID rehab service that obviously has some provisional data, but we don't have conclusive evidence with a control that it's doing what we think it's doing. So there's been a lot of interest from our direct team because obviously they all understand the importance and the value of this work, and that we can then demonstrate what we're already doing is of value, or whether we need to change anything. Because of how we developed the intervention, so the digital arm was slightly more developed than it was in the clinical service. So we've already learned quite a lot and implemented some things from that. So it's been really nice to be able to do both things at once. And there's been a lot of interest both ways. So the research team interested in the kind of clinical service, and then the clinical team interested in the research as well. So I think it's like just raising the profile of research in general, and has kind of got people's appetite up and thinking more about what else we might want to look at after that.
I think that's fabulous. And I think the COVID pandemic hit so hard to everybody that it has triggered people's awareness of research processes and how this can work to answer real world clinical questions and things that impact on everybody's families. So I'm really glad for that it has generated that level of interest from other colleagues as well. Lovely listening to you. Don't go away. Maybe you'll have questions for some of our other speakers as well. So I'm going to introduce our next speaker. I'll stop sharing and I'll invite Michael to put his slides up on screen, and then begin talking to us about his work. Looking forward to listening to you, Michael. And please, everyone, again, if you have a question, just pop a little message in the chat. It doesn't need to be your whole question, but then I could come to you afterwards and invite you to raise that directly with Michael. Okay, thank you, Michael.
Is that showing up okay?
Yes, it is.
Yeah, great. So hi, I'm Michael Hissand. I'm a research orthoptist who works for the University Hospitals of Leicester and also the University of Leicester. And I'm going to talk about one of our big completed randomized controlled trials on amblyopia. So it's kindly funded by Action Medical Research, and it was adopted on the NIHR portfolio studies. So our question was, does extended glasses wear for amblyopia treatment actually work? That's the conventional treatment. So I'm aware that not everyone will know what amblyopia actually is. You're probably familiar with other adult eye conditions. You've probably heard of glaucoma and diabetic retinopathy, but lots of people haven't heard of amblyopia, and it's actually one of the most common childhood visual diseases. So amblyopia is essentially decreased vision in one or both eyes due to anomalous visual development during childhood. So essentially, as you know, with other kind of cognitive systems, the developing brain needs to learn how to use the signals from the eyes effectively. If, for example, you've got an uncorrected need for glasses or a misalignment of the eyes, the brain doesn't get a clear signal from that eye. It just essentially ignores it. It doesn't use those signals appropriately. And although that process will start in childhood, once you've lost that plasticity and you're in adulthood, the visual system is kind of solidified and you don't have good vision in that eye. So it creates a potential lifetime visual impairment. And it's evidence it can affect your education, your career attainment, mental well-being. And there's also a risk of loss of vision of the better eye as well. So it can have some serious consequences. It's surprisingly common. It does affect 2 to 5% of the population of the UK, despite people not really knowing much about it. And it does take up a significant amount of the hospital eye appointment service burden. So how it's conventionally treated. So like I say, it's a childhood visual development problem. So we need to treat it. We've still got plasticity in the visual system. So we're aiming to treat kind of by the age of 9, we're kind of hitting our limit there. So we're treating young children here. And it's really, really simple in terms of the treatment process. First, you correct any need for glasses. See, the current guidelines suggest wearing glasses for about 16 to 20 weeks. And then if that hasn't corrected the problem, then you kind of bias the input to the bad eye by covering the good eye with patching. So that's kind of what the image on the bottom right is showing, both the combination of the glasses and the patching. So it's a really simple treatment in principle. However, you can imagine the problems of adherence in kids who don't necessarily understand why they're doing it, and compliance with treatment is a real problem. And that's kind of reflected with these kind of poor outcomes where 30% don't reach driving standard in the affected amblyopic eye. So there's a real need to optimize treatment. So the problem with the current long treatment period, to start off with just glasses wear, is we've got a 3 or 4 month period of just glasses wear where you can get declining motivation of both the child, the parents, teachers who also have to be involved in kind of maintaining compliance. And as the children get older, obviously you've got declining plasticity. And there's also the opportunity cost of we're maybe doing a treatment which maybe is not optimal. So no trials to date, although we know that glasses wear works on its own and patching works, we haven't refined kind of the timings of this. So no trials have directly compared the overall treatment outcomes between this kind of extended conventional glasses wear period and potentially a shorter glasses wear period. So that's what we did with our study. So it's the first large-scale randomized controlled trial. We're comparing our overall outcomes with and without this long glasses wear period. It's quite a big study, about 340 participants. And in order to achieve that, we had to collaborate amongst multiple sites. So we had 30 active sites across Europe, with Leicester taking the lead. And so what we did, this is kind of our study schedule. So with our 340 participants, the top orange kind of row is conventional treatment. So essentially this is kind of extended glasses wear treatment group. So the main difference is you can see for the first 18 weeks, they just wear glasses. After that, then they start additionally patching. Occlusion is patching, so they cover the better eye to force the brain to recognize those signals from the weaker eye. That's the conventional group. The other group had this kind of early patching treatment where they only wore the glasses for 3 weeks before we added on the patching on top of that. So quite a short period of glasses wear there. And our main outcome was after 12 weeks of patching, to assess what our main outcome was. We had 2 secondary time points. This study was quite interesting. We also used lots of questionnaires and we used some electronic compliance monitoring, but I think that's kind of beyond the scope of what I can cover here. So these are kind of our main results of the improvement in vision of the amblyopic, the weaker eye, during our treatment. So on the left-hand side with our kind of line graph, we've got the timeline of visits along the bottom, and we've got a vision on the y-axis. So a bigger number for vision is worse and a smaller number is better, to just kind of calibrate you with where those kind of visual landmarks are. If you're looking at the chart, the vision chart on the right-hand side, that green arrow with the 0.0 is what we define as normal, or if you've heard of 20/20 vision. The red arrow, the 1.0 at the top, if someone's struggling to get those kind of letters, they're probably in the realms of being registered as sight impaired or legally blind. A driving standard, just out of interest, is this blue arrow with a 0.3. And you can see with our group, this yellow arrow on the right-hand side, this kind of 0.7, the median kind of starting point of our participants were kind of around this 0.7 mark. So quite poor vision in the bad eye. And then returning to the line graph on the left, so you can see the glasses wear period for the gold coloured line, and that's so they're having this extended period of just glasses wear, and the vision is gradually improving. And the blue group are the ones with the shorter period of glasses wear before they start patching. So you can see, regardless of the group, we get a good visual improvement, and it's starting from this kind of 0.7 mark, getting close towards normal, maybe a few lines below that. But showing it like this, just in that weaker eye, kind of obscures a bit about what's going on. So here's kind of our assessment, our primary outcome after our 12 weeks of patching. So here we've got the percentage of participants reaching different definitions of success. On the y-axis, when we say lines of intraocular difference, here we're comparing the weaker eye and the better eye. So essentially 0 lines means the vision is equal, perfectly equal between the two eyes. 1 line would be there's a slight deficit there, there's 1 line reduction in the amblyopic eye still, 2 lines are still 2 lines difference. So that's kind of our criteria there. On the left-hand side, we've got our extended glasses wear group. On the right-hand side, we've got our early patching group. The main thing to highlight here is whatever definition of success, whether we're really tight and say we want absolutely equal vision, or we're willing to accept a few lines difference, the early patching group always seems to have about a 10% better outcome in terms of our definition of success. So it seems like the early patching group tend to be doing better. So generally, our results are showing the early patching group seem to be doing better than conventional treatment, and haven't shown the data here, but they also required less patching overall. So there's kind of less burden there. But if I return to our line graph here, you can see with our extended glasses wear, the gold group here, you can see some of them are getting down to this by the G12, about 12 weeks, or P0, they're getting down towards good vision before we've even started the patching treatment. So our question was, is there a group of patients where this extended glasses wear treatment, the conventional treatment, actually works really, really well? Because we noticed some participants reached success before we even started patching. So we went through our results and we put in all the factors of our study, whether it's age, gender, ethnicity, starting vision, all these factors, to see what was predictive of a binary outcome of success or failure, and trimmed off our tree to see which ones were had the greatest predictive factors of success. And what we found was, with a baseline starting visual acuity in the bad eye, if it's a slightly better vision of a threshold of 0.6, and they're a younger age, so younger than 5 years, 4 months, they've got quite a good chance with glasses alone of achieving success. On the other end of the spectrum, if they've got worse starting vision and a strong need on the right-hand side for a glass subscription, they're definitely going to fail. So you might want to start early patching with those, add additional kind of force them to start patching earlier. So it's kind of the start of an indication of personalised treatment. We found that there's a group that really do respond to the extended glasses wear really well. So in summary, our evidence shows early patching tends to work better than conventional treatment for, on average, most of our participants. However, we have identified this kind of group that will really respond to these extended glasses wear period. So you might want to leave them just with glasses alone for a longer period to see if you can get treatment success, even without having to do patching, so it's kind of less of a burden on the participant. Hopefully, by optimizing the treatment, can reduce the number of appointments required. Like I said before, it's quite a big service burden, with about 3/4 of our children's hospital eye appointments occupied by these amblyopia patients. And we've developed a collaborative network across Europe, where hopefully we can start some further studies in future on this same area in amblyopia. Any questions at all?
Well, I'll thank you very much, Michael, for that presentation, for that really impressive international collaboration, multi-site collaboration. Lindsay, I can see you've got your hand up for a question for Michael.
Yeah, well done, Michael. I think you made that really clear and accessible as somebody who knows nothing about your area of research. It was easy to follow, so thank you. I was just going to ask about, obviously you mentioned that adherence can be quite poor for glasses and patches in this group.
Yes.
And I wondered whether you'd done any patient public involvement work. I've done this a lot with adults, and I'm just wondering how much of a challenge it would be to do this with children and, you know, involving the parents and that side of things. So I wonder if you've got any experiences of that.
So there's been some previous research on that and what kind of the difficulties are. And a big part of this study was also, we've generated a lot of, we've got baseline questionnaires, one at primary outcome and one right at the end, to see what the kind of hurdles there are. And it's based on a questionnaire done by another team in the US who also research in this area, to try and see what the kind of hurdles are. So I didn't include this just for speed, but we have got a big part, so we're going to publish another paper just on the questionnaire data, because we did get some feedback. And I think with this kind of treatment, because you need to wear the glasses all the time and you do the patching for quite a few hours a day, it's not just the parents and the child, it's often their teachers at school and things like that where they have to be involved. And I think it's this kind of network of people where if you can get an improvement of vision quite quickly, people are motivated and everyone's motivated to get things done. But if you things are very delayed and they're kind of seeing you're going for months and months and not really seeing a benefit, I think everyone starts to be a bit demotivated and other things take a priority. So I think it's with this, I think it's kind of once you get going, you get good improvement in vision, the parents and the teachers are quite motivated and we get a good success result.
Yeah. Thank you. It's really interesting. Thanks.
Yes, I was delighted to listen to hear both presentations, one after another, talking about, sort of explaining so clearly about research design issues. So especially at randomized control trial, to build in these aspects of accessibility that Enya spoke about, whether patients are able to access online or face-to-face opportunities for treatment interventions, and then in Michael's case about acceptability. So the accessibility and acceptability of treatment, so that for patients, for families, so that we are designing, we are evaluating treatments, interventions, management opportunities for more personalised choice. Tony, thank you. I'm so glad you came in. I didn't know whether to put you on the spot there. We've got 1 minute, so delighted to hear your voice.
Yeah, yes, sorry, I was going back to the involvement of patients in this, and there is an organisation called Generation R, which is of young people who comment on research projects, and I haven't got the contact with them in UHL. There's certainly one in Nottingham, but Becky Pritchard, before she leaves, or her colleague, Sean, will probably know if there's a relevant group in Leicester, because they're very impressive in terms of being young, 10-year-olds and younger, up to whatever the top is 16, in terms of saying, this is what we think should happen. So it's a matter of trying to involve them in something that they may not have, but they may have an opinion on and are able to influence the parents and young people just by the impressive way in which they can comment. They're much better than adults in most cases.
Yeah, well, that's so important. I'm so glad you've mentioned about this Generation R. Also, as a speech and language therapist, I would encourage everyone listening on the call and to share with colleagues that there are a number of published approaches to involving people of all ages, from very young children to adults with communication disabilities, for them to be able to be facilitated to give their own voice and opinions in this type of consultation. So communication disability or age, none of this should be a barrier to being able to participate in these types of consultations about research. Okay, time is running away with us, and I'm delighted that Ruth Garner will be our next presenter. So Ruth, I know you're on the call. If you'd like to share your screen, I invite you, please, to present about your work that you've prepared to talk to us about today. Thank you very much.
Thank you, Hazel. Just check this loads fully. Is that okay? Lovely. Thumbs are up. Fantastic. Thank you. Hi, everybody. So yes, my name's Ruth Garner. I am a clinical research associate occupational therapist, or I have just been. My secondment is now finished. It's quite a mouthful. Just to explain what that is, over the last 3 years, I have been doing both clinical work as an occupational therapist and also my own independent research project. And I have been able to split my time 50% as clinical OT and 50% as a researcher. And I've been supported by Leicester Partnership NHS Trust and also De Montfort University. So this project has been completely designed from my own interest. This was a completely open field for me to be able to decide on what I would like to study. And for me, meaningful activities in community hospitals is where my passion sits. We are very lucky here in LPT that we have meaningful activity coordinators. So during my presentation, you'll hear me mention the phrase MAC, and that refers to the Meaningful Activity Coordinator. Okay. I did this on the back of my bronze scholarship, like the internship that it's now called. So I was able to build on that, which has been really nice for me to be able to do so. So just as a bit of a background, as it says here, the activities people carry out in hospital are very different to what they might engage in at home. And that disruption can lead to quite significant psychological and physical consequences. As I'm sure you'd appreciate, when you change environments, if you go on holiday, those activities change. And coming into hospital can be quite different too. There's been studies around the world in the Netherlands, Italy, Australia and Hong Kong, and they're all saying very similar things in that the activities that patients do when they're in hospital are very different to what they do when they're at home. A study closer to home was done by Clark in the UK, and they found that patients are reporting boredom, they're sitting doing nothing, and that time passes really slowly. And that's not a great experience for our patients. So what I wanted to do was to look a little bit deeply as to what our patients are doing here in our community hospitals in Leicestershire, and to see if the impact of meaningful activity coordinators that we have any impact. So our meaningful activity coordinators, our MACs, they work Monday to Friday, generally sort of 9 till 5, 8 till 4, and they are employed purely to provide activities to our inpatients. There is a MAC on every community hospital ward now, and unless there's obviously a vacancy, but there is space for them to provide activity provision on all of our community hospital wards. And they're generally for older people that have come following medical conditions, exacerbation of existing chronic conditions, or more commonly falls. But the activities that our MACs provide are patient-centred. The impact of that meaningful part of their job role is really important. It needs to be meaningful to those patients. And they do provide activities out of their resources that are then meaningful. And as you can see, there's gardening there. There's been themed activities around Macmillan's Coffee Day. Of course, the Jubilee, where there's Union flags everywhere in our hospitals, of course. But there's also the butterflies that you can see at the top. So this was for a lady who previously enjoyed knitting and crocheting, but sadly, due to her physical abilities, was unable to continue that. But they found activities that were still meaningful to her involving wool. What is important now is that the MACs aren't providing activities that are led by our therapists. These are completely led by our patients. So I'll just chat a little bit more about that as we go through. So my study was looking at wards that do have a MAC, wards with a part-time MAC as full-time, part-time, and a ward that does not have a MAC. I carried out patient observations for over 12 hours and 12 participants kindly agreed to that, and 10 of them agreed to an interview afterwards. Once I'd completed all the observations and interviews, then I carried out a staff focus group on that ward and was able to feedback preliminary findings, which was very helpful, being as I know research can sometimes take a little while to bring those results through, but I was able to do it really quickly. And that ward were then able to change things based on the observations and interviews specifically for their ward. So the key findings from my study was technology, well-being, and also access to activity. So some of you might recognise these people here. They are Jenny and Lee. They are from Gogglebox. And one of the things that our patients reported was how much they enjoyed watching television. And we are now watching people watching television on television, which I think is a real big circle there. But actually televisions weren't available for all of our patients, and that made them feel quite disconnected from the world. They weren't really hearing what was happening in the news and weren't able to keep up with their quiz programs that they enjoyed. They also reported that the connectivity for the devices that they brought into hospital was really quite poor. So out of the 12 participants, 10 of them had a mobile phone, 6, that's half of them, had a tablet, and 2 had an e-reader. But the connectivity to their Wi-Fi and the reception really brought about frustration and isolation, and then also dependence on staff bringing landlines to them. Our next finding was well-being. So our patients had reported that that they really enjoyed having some kind of pre-sleep routine. Having a chat as well was a really big uplift. So just chatting with our patients is something that all staff on wards would like to do more of, but we're finding actually that time is obviously of the essence. Our MACs have that dedicated time. They can sit and chat to patients about what it is that's important to them and what's bothering them. But what they're finding is that some of the staff are lacking those skills to support the emotional needs that patients are bringing in, whether that's directly from the pandemic. But a lot of our patients are housebound, as we all were during the pandemic. So I think looking at some of the skills around that is important. The therapists fed back in the focus group that our patients were more enthusiastic as well, having been seen by a MAC. And whether this is just a correlation, this would be interesting to explore further, but more participants were sat out of beds on wards with MACs. So whether that's changing the atmosphere on the ward, people more positive, but it's an interesting finding. And the last one is the access to activity. Now, these are activity trolleys. These are on all of the wards in our community hospitals, so patients can access the activities themselves or their families can. But not all staff were aware that they had an activity trolley. It's just a reminder for staff turnover. On the wards with the MACs, the participants actually reported time passing quicker and there was less report of boredom. So I think that's a really interesting finding, and also just supports the fact that activity can have a really big impact for our patients. Also, the patients felt that they enjoyed socialisation, but we weren't able to bring them out into day rooms at the time because of COVID restrictions. But hopefully that can be restarted and we can start socialising our patients more and more with others on the ward. So my last slide here is just to summarise that the employment of the meaningful activity coordinators, as well as that access to the familiar activities, though, like things like your technological devices, it really contributes to the experience of engagement in occupations within that ward environment. And the importance of access to technology and social connectivity really shouldn't be underestimated. We're all social beings. We've probably all got a mobile phone next to us, and being able to keep in contact with our loved ones, being able to do those things that we do through our phones, whether it's social media or watching TV or carrying out the quizzes and games on our devices, it's really important for our patients to be able to continue that and to maintain their well-being whilst they're in hospital. And that concludes my presentation. Thank you.
That was fabulous. Thank you so much, Ruth. It was really powerful to listen to what you have managed to demonstrate through your own practice-based project, and to be able to disseminate, to share that with colleagues, and hopefully wider too. So it's that dissemination with the emphasis on what are the implications for services and for colleagues. And that's such an important part of closing the loop of any work that we undertake. Can I invite, are there any questions for Ruth? I can't see. Oh, Lindsay, you've got one there. I couldn't see anyone else's. I'm pleased you've got a question.
I've always got questions. I was just going to ask Ruth, not really about your project, but for you, what's next? Because obviously you said your secondment's ended. So have you got the next sort of step in your academic journey?
Yeah, I've now got the buzz for research. I would like to carry on this as much as I can, and I'm currently pursuing ways to start a PhD and to build on the findings from this project. I think there's some really interesting findings from this. It could go in many different directions, but I've had an offer to start PhD. I'm now trying to find the funding to be able to put that into practice.
Oh, great. That sounds fab.
Yeah, that's lovely. And that just affirms as well a comment from Michael, which is in the chat that people will be able to see, that to be able to gain research experience, to get little things, it doesn't matter how small the project, get it under your belt, but keep a record of it, add it to your CV. And there might be opportunities for taking on a part-time research delivery role, or working alongside someone else who's already running a project. But any types of opportunities, which may include working on portfolio studies, add it to your CV. But also we're encouraging people to think about keeping what we call an impact CV. So it's not just an activity of what did you do, but what was the consequence? What was what did that generate in terms of changing services and leading on to other things for other colleagues, for other services, and for the patients and families. So that's something, we've got some templates that they're already in the public domain, but as part of our national strategy, we're trying to encourage people to undertake all sorts of activities, might be clinical audit, small scale, local projects. Get it on your CV, but think about measuring impact and value as well. Thank you, Ruth. Thank you, everybody, for listening. And I'm going to invite our next speaker now, who is Shifa. So, Shifa, I know you're on the line. If you would like to share your slides and get ready to present and tell us about your recent work, that would be super.
Right.
Lovely. Yes, I can see your slides. They've come on. Thank you, Shifa.
Oops. Have I gone frozen?
Yeah, we've got the first slide, which is just a blank background. I can hear your voice, but I can't see you. So if you want to stop sharing and start again, if there's a glitch, don't, just take your time. I'm sure it will come.
Yeah, I'm trying to escape, but it's not letting me. No?
Take your time. It'll be
there we go.
There you go. Now we've started. Yeah.
All right, good afternoon, everybody. My name is Shifa Jusaf. I'm the Band 6 physio at the Evington Centre for the MSOP wards. That's your mental health service for older people. There are 4 wards in the list in LPT. The 2 wards at the Evington Centre are your organic wards with your dementia patients, and the 2 other wards at the Benyon Centre with your more functional patients, which are your anxiety disorders, depression, bipolar disorders, and so forth. So my systematic review that I'm going to present today partly is part of a bigger project that I embarked on about a year ago, very optimistically, I have to say, and I haven't gone that far on it as I would have loved to. So I'm going to give you some background on the bigger project, which is a quality improvement project that I've started. And the title is the impact of a medication alert tool and false risk assessment tool in a mental health for older people in patient setting. It is reported that around 850,000 people in the UK now lives with dementia. Yes, with dementia. Most of them are over the age of 65. According to the Alzheimer's Society, inconsistent hospital recordings of the number of people with dementia who have fallen means that this data is only available for about a quarter of the hospitals. But even in that small number, 6,834 falls were reported last year. Because I'm working in the dementia ward, I took a slightly more approach more towards dementia than your functional patients. So in our dementia patients, we have something called PTSD, which occur in most patients with dementia, even though it has not been defined in the classification criteria of dementia yet. I don't know if it will be. There's lots of talk about that. It's well known and well researched fact that patients over the age of 65 with dementia have an increased risk of falling due to poor risk assessment and risk awareness. They have slower speed of processing and alterations to executive function, that is your planning and your judgment, and also the burden of comorbidities that are compounded by the exacerbation of polypharmacy indicates the burden to the quality of life of these patients with mental health issues. A couple of my slides. It was so good, the reception in the room where I sat. I decided to sit in this room because it's got the best reception in the Evington Centre. Clearly it doesn't. There we go. In terms of falls and false risk assessment, the World Health Organization defines a fall as an event which results in a person coming to rest inadvertently on the ground. Falls are a public health challenge, particularly for countries with an aging population like us, and represent a significant burden in terms of cost for the NHS. Falls are important for health systems as their occurrence places a burden on the health services. And there's a lot of numbers of how many patients have fallen in and around our hospitals in the UK. According to Narayan, within the UK, most trusts use unvalidated assessment tools, and trusts using validated tools prove to have inconsistent and predictive accuracy. This review that I've read includes that all mental health wards within the UK, of the 56 trusts that were invited to submit their policies, 46 complied. And from their research, the false risk assessment tools, and from that research, the false risk assessment tools used in the Leicestershire LPT Trust, 57% was positive predictive validity and 86 negative predictive validity. Subsequently to that, a multifactorial false risk assessment tool was developed in the LPT, and it was adapted. And that is what we use on the EMSA boards at the minute. But with our mental health patients, that is not enough. We do not get the correct information from these tools because on admission, the nurses do not have access to what medication they're on, their falls history, and those are important things for us on the EMSA boards to have knowledge of before we actually do an assessment and decide on their treatment. A little bit about psychotropic medication, because that is one of the things that is vitally important in using on our wards. So the understanding of the effects of medication on falls mechanisms is vitally important. Falls can be caused by almost any drug that acts on the brain or on circulation. Usually the mechanism leading to fall is one or more. Sedation, or slowing of reaction times, impaired balance, hypertension, including orthostatic postural hypertension, which we find a lot on our wards, bradycardia, tachycardia, and those are all things that are present in our age population of our patients. And as patients living with dementia often suffers from comorbidities like your cardiac disease, your diabetes, the amount of medication they are on, sometimes patients come to us and they are on 10 different medications. And on top of that, because they were agitated or aggressive at the care home or at home before they came to us, they were given lorazepam or some kind of benzodiazepine. And so when they come to us, they are maybe on something like 12 different types of medication. And definitely one of those or combination of those medications definitely impairs their cognition, which is very impaired, and their balance. And that. So the objective of the study was to undertake a systematic review on the impact of polypharmacy and the combination of certain drugs, not always antipsychotics, but different, like amlodipine. There's a different sort of drug that acts on the patient feeling quite sedated or unsteady gait, and all of those different factors. And there was a need to clarify conceptual boundaries on this topic for MSOP. So from the literature review, the author will develop a medication alert tool using datasets from the polypharmacy and non-medication different combinations that poses a false risk. And we will try and put it on an EPR, on our EPR system, in consultation, obviously, with a multidisciplinary team, including your IT technicians, your pharmacists, pharmacy technicians, nursing staff, and medical staff. And that is quite a big project that we're going to embark on eventually. And then to develop the threat that is suited to the needs of our mental health patients exposed to polypharmacy. And that is quite a big deal, because we are going to try and change policy on false risk assessments. So it's quite a big controversy to dip your toes in. But in time, we'll try and see if we can develop a threat that is suited to our patients' needs who are exposed to polypharmacy. And obviously, it's lovely to see Tony, because one of my main objectives was to create this public patient involvement group for mental health older patients in Leicestershire, because we've got like a wide range of languages, ethnicities in Leicester, and they're not always drawn upon their lived experiences, their life stories, and I think it'd be really good to get that off the ground. So at the minute, Dr. Hari Subramaniam, one of our consultants, he has started that and has kind of recruited me onto that. So we will hopefully will have to speak to Tony as well and get his advice on how to get that off the ground. So for the actual systematic review, what we did the pilot search was undertaken with the assistance of the UHL librarian, and the keywords were finalized. There was no limitations regarding data publication or language, and there was no restriction on the design of the studies that we used. The exclusion criteria was anybody younger than 65 years old or in residential care. And the inclusion criteria was everybody over 65-year-old and who lives in a nursing home or suffers from PTSD. The keywords we used in the search strategy was dementia, inpatient falls, polypharmacy, mental health, and with the assistance of the UHL librarian, the following electronic databases were searched: Senel, Psychinfo, Embase, and Medline, and it defined search, revealed 32 titles. And I just have to mention that in order for me to do this, because I'm fully clinical, with Suraya Hassan and Charlotte Catalan from the University of Leicester, we managed to create a research placement, which was in April, May earlier this year. And with the help of the students, we managed to do this bit of the research. So I had 2 physio students with me, and we reviewed the titles in parallel. We unfortunately had to do it on Teams at that point because of COVID restrictions. The physio and one student 100% agreement on the titles, and one student had a different opinion on one. And with discussion, there was then 100% agreement on the abstract we chose, and 14 abstracts were chosen in the end. And that is where we are at the minute with the study. It's ongoing, and it has been delayed through staffing constraints and times. And because I'm fully clinical and there's no protected time to do QI projects, it has been a little bit difficult. But luckily, I've been recruited onto a different study, and will hopefully going forward have 1 day of research to be able to continue with my research. Thank you very much.
Thank you so much for talking to us about this project today, Shifa, because I think that we all understand a systematic review is a massive piece of work. But when you begin to know the statistics, that normally you could expect a systematic review to take maybe 2 years with a whole team of researchers working on this, it begins to put into perspective what an enterprise it is to embark on this type of thing. Evidence reviews are vital for us to make sure we use the existing evidence to answer clinical practice questions. But we need to be more aware of a range of different rapid review approaches and designs, as well as a very traditional systematic review. So I'm sure that people will have some more questions for you about your experience of doing this systematic review. I'm delighted to hear you say at the end of all that you're still motivated to continue with that review to get to the conclusion, but also to continue in research activities. So that's super to hear about. Any questions? Anyone want to pop up their hand or have a question ready for Shifa? Okay, well, I'll wait another minute and see if anyone does have a question. In the meantime, I'm going to mention, just for interest for people and for you, Shifa, and everybody else, about what my comment just now about a range of designs which are called rapid review approaches. So they go from a very traditional systematic review. They include things like best evidence for best medicine, BME review, a CAT review, critically appraised topics. These go down in terms of time commitment and time scale for completing the review. And particularly the CATs, the critically appraised topics, is an approach which has been designed to be undertaken by non-academics, by people like, frontline practitioners who don't have time, don't have academic mentorship, don't have necessarily previous experience of undertaking traditional systematic reviews, but using this, following this approach and discussing with a team, can be undertaken by one person, but much better to discuss within a team how this rapid review approach can answer real-world clinical questions by just picking out selectively the top hits of findings from your search and looking to see what are the take-home messages, what we call the clinical bottom line messages that are emphasized for implications for practice. And that might tell you to reassure you that actually, no, carry on with what you're doing, or it might flag up some things to discuss when you're within your team, or to go then at that stage to your local librarians, knowledge services, as you've described, Shifa, what a boon they are. And we need to work more in partnership and take advantage of the services they can offer to help us do more extensive searching. Okay, wanting to keep to time today, and we have one final presentation to come. Last but definitely not least, I am going to introduce Fiona to present her work. So Fiona, I can see that you're online, and yes,
Sorry
we can
to
see,
interrupt. There is
we
one
can see.
question
Oh,
for
I didn't
Shifa.
see it.
It's okay, it's
Okay.
just popped up.
Well,
Can
we'll
I
leave
just
Fiona on screen, and yeah.
I'll read it out. So it's from Lucy Gardner. Thank you for your presentation. You've mentioned some of the barriers faced in relation to conducting your project. I wondered what you think have been the facilitators. You talked a lot, I think, about what the challenges have been, but what has made things easier as a full-time clinician doing a review.
Yeah, so it has been really difficult. And I think having the students for that 6-week period did make it easier for me to continue to do that. And I think going forward, having students on a research placement will definitely help me out with that.
Yeah, so having a bigger team than just you.
Yeah. And luckily one of the consultants has come on board as well. So, and I've got the assistance of the OTs on the team. My actual team on Evington is really good. But still, they're not doing the research. They're just helping me out on clinical duty so I can do the work.
And one more hand up. If we take one more question, and then I will come directly to you, Fiona.
It's not really a question. I was just saying that Shifa, I think I'll reach out to you in regards to the student part that you were talking around, and hopefully we can get something set up. I'm talking to research and development in LPT to try and see whether we can do a research placement, a more established placement. So I'll reach out to you, and maybe we can look at piloting a student, hopefully. Another one, hopefully.
That will be brilliant. Thank you.
Excellent. New connections, great win-win situations. Okay, Fiona, over to you. Thank you for being patient.
It's okay. Hi, so my name's Fiona. I'm a therapy radiographer, and I've recently started a new role as an advanced practice radiographer in neurology. So my role will be to further support men with prostate cancer undergoing radiotherapy treatment. So just a bit about radiotherapy. So prostate cancer is the most common cancer among men in the UK, and currently the majority of prostate cancers are diagnosed while it's still localized, and the prostate cancer is still contained within the prostate gland, so it's not spread to other parts of the body. And with advances in treatment modalities such as surgery, radiotherapy, and androgen deprivation therapy, so hormone therapy, there are excellent survival rates, with 87% of men in England surviving the cancer for 5 years or more, and 78% surviving for 10 years or more. So a bit about radiotherapy. So radiotherapy is the use of ionizing radiation, such as high energy X-ray beams, and they are targeted directly into the patient. The beam is generated externally and with no radioactive sources placed within the patient. The radiation causes breakdown in the cell's DNA, affecting the cell's function and the ability to divide, causing the cell to die. So the aim is to destroy all the cancer cells with minimum impact to surrounding healthy tissues. So the radiation beams can be planned to match the prostate size and shape. However, the extent that we can do this is limited, so which can cause a number of side effects. So men usually feel quite fatigued during their treatment, and also because of the close proximity to the prostate to the bladder, the rectum, and the penile bulb, parts of these structures can be included within the treatment area, causing a number of side effects, which are like increased urinary frequency, increased urgency, increased bowel frequency and urgency. Some men might have a mucus discharge, increase in wind, problems with their bowels, diarrhea, constipation, burning when you're urinating, and often impotence as well. Now, hormone therapy is often given alongside the radiotherapy treatment. Sorry, I lost where I am now. So prostate cancer uses the male hormone testosterone to grow. So the testosterone controls how the prostate grows and develops. So the reason we give the hormone therapy is to stop the production of the testosterone and therefore stop the cancer from progressing. So men undergoing radiotherapy for prostate cancer will normally receive 3 months of hormone therapy before they start their radiotherapy. And this will last throughout their course of treatment and often for up to 3 years in total. Sorry, I'm going through. So I think I've lost the slide. I'm very sorry. So I'll just continue on. So the hormone therapy also comes with some other side effects, which they can be a lot of changes to like more sexual dysfunction, so loss of libido, changes to the size and shape of the penis, difficulty getting erections, and also have other side effects to physical side effects such changes to a man's body shape, so weight gain, loss of muscle mass, and they also might notice changes to the way they feel about themselves, such as feelings of like a loss of feeling demasculated, or people feel quite depressed as well. So it's a hard time that these patients have to go through. So due to the fact that the quality of life of these patients is affected so much, it was felt that a service evaluation was needed to gain an insight on whether we're meeting the needs of this group of patients. So a questionnaire was sent out to some past patients, asking them about their experiences, how they felt before treatment, how they felt during treatment and after treatment. So it was found that 71.5% of men felt they were confident that they were informed of all the possible side effects, but only 50% of men felt they were informed of how to manage these possible side effects. Only 39% of men felt nutritionally prepared for the treatment, and 41% that felt they were mentally prepared, and only 32.5% felt they were physically prepared for the treatment. So after collating these results, it was felt that changes were needed in order to help men come in for radiotherapy and help them to feel more supported. So it was felt that setting up a one-to-one prehabilitation would help to reduce some of the anxieties patients feel following a cancer diagnosis, promote healthy lifestyle changes with such discussing diet and exercise, give patients and their partners a chance to ask questions regarding the treatment, and give information on possible side effects, including changes to sexual function, and advice on management with early intervention, such as different medications, different devices, and pelvic floor techniques. It would also give us a chance to discuss bladder and bowel preparations that we need when we do the treatments in order to reduce some of the side effects. And also, because when we're doing the treatment, what we do try to do is to have as less of the normal tissue in the area as we can. So we try to stretch the bladder, so there's a smaller percent of the bladder that's within the target area. So another thing is the men have to come in and they have to have a full bladder during treatment, and a lot of them do feel anxieties about that. So just to get them prepared and get them used to having a full bladder for their treatment as well. So we did think that there were some limitations of this, because it's only one-to-one. It might not be enough to encourage the patient to make healthy lifestyle changes. There'll be no practical information on exercises, and there'll be no specialised teaching on exercise, pelvic floor techniques or diet, and no peer support. So I don't know, some of my slides seem to have gone, so I do apologise. So in future, we thought it'd be great to set up a multidisciplinary workshop in a group setting, as this could also incorporate peer support. There could be advice from a number of different healthcare professionals, such as physiotherapists, dietitians, occupational therapists, and sexual function specialists. It would also help patients. It also helped to normalise some of the concerns and symptoms, so patients can discuss what they're going through with other patients, and it would just help them to see that someone else is going through the same things that they're going through. And also, men that would not normally voice their concerns might learn from other people that would ask questions and that felt more confident to speak out about what they're going through. So that's it, really.
Thank you so much, Fiona. I mean, you've conveyed the impact of this devastating news on men and their families. So yeah, I think we all have been thinking about your proposals for different types of support, whether it's one-to-one or group or whatever. But I think the important thing is that these next steps are co-designed. We had this conversation earlier. Tony may wish to make a comment or offer any help or guidance on how you could get support for that. Or maybe there's any other questions. We've just got a time for another question before I go back to the final slide and give Lindsay the closing word. Tony, I can see you there on screen. Over to you, and Fiona, if you would please stop sharing, and then we can pass to Lindsay to close the event after Tony's comment. Thank you, Tony.
Well, it's pretty important to obviously try and have preliminary discussions, not just with individuals, but with groups, so that they can share anxieties and what they may feel are their needs. And this presumably can be arranged because you know the target group. You then try and get them together to a preliminary group meeting to discuss the issues that are involved, because then they will have some greater understanding, and some of the things which you've described are clearly going to be stressful for individuals to cope with, not just physically but mentally, and discussion amongst individuals helps to allay some of those anxieties.
Many thanks, Tony. Many thanks. I'm just going to pass to Lindsay to conclude this excellent session.
Well, thanks, Hazel. And thanks to all of the speakers who've given the time today and explained the research so clearly. Obviously, it's been a very diverse set of occupations that we've managed to cover today, which I'm really pleased about, because when we ran this session last year, it was predominantly physio heavy, I would say. So it's been really nice to hear from some other professions, and I've certainly learned a lot. So thank you. Thanks also to Hazel for chairing the session and giving us your valuable national insights. That's been really useful. So the recordings will be available soon. We'll also be emailing you a certificate of attendance. Please do share the recordings with your colleagues who weren't able to come today. We do have a feedback form, which is on the slide here, and I've also put it in the chat. So that's for you to give feedback, not only on this session, but any session that you attend this week. It will help us for planning for next year's AHP event. So we've got other sessions on this week, and then obviously Friday's the big day, AHP day. So we will be able to join the live stream with Suzanne Rastrick, and I'm sure locally you'll be doing lots of things and eating lots of cake, I'm sure. So I'm actually going to my son's school this afternoon to talk about AHPs, so I'm taking them some cakes as well. So yeah, it's going to be great. So thank you everybody, and enjoy the rest of your week. Bye.